I'd like to first start the education class by introducing myself. My name is Carrie, and also introducing my colleague Gail. Together, Gail and I will provide the education class around managing your health after breast cancer care. And we sort of tag team the class, and so we each have different slides that we will provide the information on. Both Gail and myself have over 20 years of breast cancer oncology nursing experience. I'm the nurse within the Wellness Beyond Cancer program, and Gail is the nurse practitioner within the Wellness Beyond Cancer program. Welcome, and thank you for joining us online for our breast survivorship education class. Truly, this is a time of great hope and a time to celebrate as you transition from the cancer center and back to the care of your primary care provider in the community. Your hard work has paid off, and your oncologist would not have referred you if they weren't confident. So many people do so well now after a diagnosis and treatment for cancer. However, they're living with the late and long-term side effects due to their treatment, and they're nervous around what to report should a reoccurrence ever occur. When a patient goes through the Heart Institute, for example, there was always a standard of care around the rehabilitation process, the same as a car accident. Victim would then be rehabilitated through the rehabilitation center. Survivorship programs are about rehabilitation around cancer treatment and cancer diagnosis. And so we're going to touch on a number of topics today that are reported not only by the patients that we have had over the last number of years, but is also reported in the literature as being the most common side effects due to treatment and the most common concerns that patients report. There's a number of objectives that we're going to cover today, and they're listed here. I won't read them off. What we'll do is we'll indicate each of these objectives as we move throughout the education presentation. Many people wonder where the Wellness Beyond Cancer program name comes from. Well, in essence, it is the Ottawa Hospital Survivorship Program. However, at the time when the program was being planned and developed, patients were involved in the planning and overall development from the very beginning. And some patients told us, not all, but some, that they weren't comfortable with the word survivor or survivorship for whatever their personal reason was. But because of that, we recognized and heard these individuals and decided upon, as a group, to call our program the Wellness Beyond Cancer program, because truly we're trying to help you move beyond a diagnosis and treatment and back to the best possible quality of life that you can have. The first objective that we would like to start with is to provide you with an overview of the Wellness Beyond Cancer program. Organizations may have slightly different definitions for when survivorship care begins, and organizations may have slightly different models of care within their institutions. At the Ottawa Hospital, the Wellness Beyond Cancer program's purpose is to ensure that all people at the end of their active cancer treatment have access to the appropriate follow-up care and resources that are required to best meet their individual needs. And so your oncologist with you made a decision based on how you were feeling, and at the end of active treatment, that it is now time to transition you back to the care of your primary care provider in the community. The Wellness Beyond Cancer program offers a few key objectives that are listed here on the slide. And the first one is the survivorship education class, which you're listening to right now. And also, it's to provide you with a wellness care plan, and the care plan is also provided to your primary care provider. This has not been spoken about just yet. I will in just a few minutes describe what a care plan's purpose and so on is. And the majority of you listening will not have received your care plan just yet. Why we bring it up in the class is to provide you with a bit of information around it, so when the clerical team contacts you for your care plan visit, then you'll have an understanding of what to expect. Also, for those of you that are being followed by the nurse practitioner in the program, it is at the time when you transition away from the nurse practitioner and back to your primary care provider in the community that she will provide you and your primary care provider with a care plan at that time. Also, we're very fortunate in Ottawa to be surrounded by wonderful healthcare services and resources, but you can't access what you don't know about. And so, if there are outstanding needs that you have, some symptoms that are still troublesome to you, then we can help link you back or to regional resources that could be very beneficial for you. The phone number that you see on the slide is the direct phone number into the Wellness Beyond Cancer program. And at the time of the program's development, patients and primary care providers told us that they were thrilled to be transitioning out to the community and that you were transitioning back to their care. However, they wanted a direct link back into the program should that ever be necessary in the future. So an expedited reentry, but also it's a contact number that should your primary care provider in the community have any questions or concerns, they have a direct link that they can contact us and we can address their questions. And if necessary, either have you reassessed by your oncologist as need be. Also, just to let you know that there are other available survivorship resources on our website, and also the patient learning links is a great resource for patients within the Cancer Center and for anyone that wants to go online and access the information. It is the online Ninon Bork Library. So just to review the overview of our survivorship program, this is a very simplistic slide. We call it our running man slide, but what it does is it offers you a visual as to the beginning, middle, and through to the end of our program. And you're not with us for very long, actually. When you look at the blue box, the first one over furthest to your left, this refers to the time of referral to our program by your oncologist. That oncologist was either your surgical oncologist, medical oncologist, or radiation oncologist that together with you decided it was now time to transition out to the community and back to the care of your primary care provider. At the time of referral, your oncologist made a decision based on your specific needs whether to transition you through to your primary care provider or to be followed by a nurse practitioner for a period of time in our program until both you and she feel that you're now ready to transition back to the care of your primary care provider. And transition to your primary care provider is the goal of the program, regardless of which of the two streams that you're referred to. We call them streams, either the green box to your primary care provider or the nurse practitioner stream, which is the yellow box. At the time of referral, regardless of which stream your oncologist has referred you to, you completed a needs assessment checklist. And if you can recount back to the day that last visit in the module with your oncologist, you may recall filling out the needs assessment, which is about a 3-page document asking you about physical and psychosocial needs that may be outstanding for you. The purpose of that needs assessment is to highlight to yourself and to us and your primary care provider those specific needs that are self-identified by you. If you indicated them as being moderate, or a 3 out of 6, to extreme being 6 out of 6, then it is populated onto your care plan, which I'll speak about in just one moment. The red circle around the blue box that says the education class, Living Well and Managing Your Health After Cancer, is where you're at right now. This is the education class that you're participating in online. Then what happens after this education class, you will be notified by our clerical team to book you for a care plan review visit if indeed you are part of the green box, that being out to your primary care provider, or you will be contacted by the clerical team if you fall within the stream of being followed by the nurse practitioner for a period of time until you eventually transition to your primary care provider. If you're not sure which of the two streams that you have been referred to, then you can call us and we can help you by identifying which stream your oncologist has referred you to. Again, after the care plan review is done with one of the Wellness Beyond Cancer program nursing team members. Then you will then have your follow-up care with your primary care provider. At the bottom in the yellow boxes, if you're followed by the nurse practitioner, which may be one visit or multiple visits, depending on what you and she decide upon is required. Once you transition back to your primary care provider, the nurse practitioner will review your care plan visit at the final visit, and then follow-up will continue with your primary care provider in the future. Regardless of whichever stream that you fall upon, once you are discharged back to the care of your primary care provider and you're being followed by he or she in the community, we do offer an expedited reassessment or reentry to the cancer program if that is ever required. And our oncologists have really wanted us to stress that to you, that we will always be here and they will always be there for you should you ever require it in the future. We can make that happen very quickly without having to go through the new patient process as you once did in the beginning. So I mentioned earlier about survivorship care plans. The majority of you have not yet received this document, and why we talk about it during the class is that when you're notified by the clerical team about your care plan review visit, you'll have an understanding of what that visit will be about. If you're being followed by the nurse practitioner, this care plan will be provided to you at the final visit before discharge back to the primary care provider. Care plans refer to two simple words in survivorship programs across North America, really, and the world. And the purpose of care plans are essentially twofold. Number one, they provide you and anybody that you wish to show this document to with a treatment summary, the treatment that you had for your breast cancer care. The second reason for a care plan is, yes, the treatment summary is my past, but what do I do going forward? What are the recommended follow-up tests that myself and my primary care provider need to follow to ensure that I'm staying well? These surveillance follow-up tests or the recommended follow-up guidelines are based on years of research that informed oncologists and care providers around what tests are required for women during their follow-up care. They're based on the Cancer Care Ontario guidelines and as well the ASCO guidelines, which stands for the American Society of Clinical Oncology. They're what our oncologists endorse in the Ottawa Hospital Cancer Centre. It's what they have been following while they have been following you within the cancer center. It now provides a lot of clarity to you and your primary care provider as to what tests and follow-up recommendations should be followed in the future. As well, the final component of this short document, and we do make it as short and concise yet comprehensive as we possibly can, is the summary of patients' self-identified needs. As you recall back on that trajectory or that running man slide of while you're with us in the Wellness Beyond Cancer program, I mentioned the self-identified needs, those needs that you indicated at the time of your referral as being moderate to extreme. Populate onto this care plan because it is a wonderful communication between yourself and us as the wellness team, or between yourself and your primary care provider in the community as to what needs or what symptoms are still troublesome to you. And by flagging these needs, it helps us or your primary care provider to link you up with the resources or to review with you some strategies to help manage those symptoms. There are 3 copies of this document that are created. They're all the same, but one is provided to you at your care plan visit. The second one is kept in our cancer center chart and will be with us in the future if we need to look back at it. And the third copy is mailed to your primary care provider in the community along with the discharge letter from your referring oncologist. Some patients have shared with me some things that they find helpful around the care plan, and one of them is to make a copy of the document. Put one away for safekeeping, and the other one you can use as a working tool, always keeping it up to date as tests and time move along. Some patients have also shared with me that they'll take a copy of this when they travel. And it's always nice if you ever need it to be assessed by a healthcare provider, it's a great document that you'd be able to pull out and show it to them. Because as we know, it's difficult to rely on our memory as time moves on, but also when we're stressed at an appointment, for example. Women will use it when they go to see a specialist if they ever need to in the future. Again, it's a great document to share with a specialist their breast cancer treatment summary. So once again, it saves them relying on their memory. And other patients have also mentioned what they'll do is they'll scan it, the original document, into the computer so that they're always able to have it available should they ever need it in the future. So we'd like to take a moment to talk about the purpose of follow-up care and why it is so important after your active cancer treatment. Well, we can't ignore the elephant in the room, that one very important reason for proper follow-up care is to detect a reoccurrence of cancer at its earliest stage. However, there is a number of reasons why follow-up care with your primary care provider is so important moving forward after cancer treatment is completed. Primary care provider is a term that is used for family physicians or nurse practitioners in the community. And there's been a lot of work done around the role of primary care providers in ongoing cancer follow-up care. And what the literature has shown is that primary care providers are as equally equipped to look after cancer patients long-term as an oncology specialist. But in fact, they showed superiority to a specialist care in ensuring that the rest of you is looked after. Once you come into the cancer center, a lot of the focus is around the treatment for your cancer. And the rest of you can sometimes get negated. For example, monitoring for cardiovascular health and so on. And so while the detection of reoccurrence early is so important, it is also important in follow-up care to manage and monitor those side effects that you may have from treatment, to also screen for other potential cancers going forward, and ensuring that the rest of you is looked after. Again, for example, your cardiovascular health, screening for diabetes, other cancers, and so on. Each time you're seen in the cancer center by your oncologist or by one of us in the Wellness Beyond Cancer program, there is a dictated note that is sent back to your primary care provider. So while you've been cared for in the cancer center, your primary care provider has been getting notes on you all along to know where you are at with your treatment. And this has ensured that continuity of care moving forward. And a primary care provider can ensure continuity of care for all of you moving forward, not only for your oncology care follow-up, but also to ensure that the rest of you is staying very well. It's important to remember, too, that follow-up is important even if you don't have symptoms. And Gail's going to talk to you not only about the screening programs in the province of Ontario in just a moment, but also around the follow-up guidelines. And one of those guidelines is being seen by your primary care provider on regular intervals of time. So who is involved in your survivorship care? Well, looking at this visual diagram at the top is the Wellness Beyond Cancer program team. And perhaps you've already spoken with one of the clerical team members on the phone. Also, at the time of discharge and care plan review, you'll meet one of the nurses. The nurse practitioners will follow you throughout if you've been referred to the nurse practitioner stream until it's time to be discharged to your primary care provider. The community resources are what I've mentioned that are available in the community that we can link you up with to help best meet your individual needs. Your oncologist has been there for you all along, and Dr. Roanne Siegel, who is our medical lead for our program, really wants us to ensure that you receive the message that your oncologist will be there for you should you ever need them in the future. And again, as part of our program is that important re-expedited entry back into the program should that ever be needed. Your primary care provider has been there for you all along, and I just mentioned previously that they've been getting notes on you all along each visit while you're coming to the cancer center, and that is included when you're seeing one of the wellness program team members. Family and friends have been part of your diagnosis and your support team throughout. And going back to my days in the Women's Breast Health Center, many women told me that it was very surprising at the time of diagnosis. The people that were there for them and supportive for them were perhaps not the people that they expected to be supportive for them. And yet they were also surprised in realizing that the people that they felt would be there for them were not. And so the message around family and friends is to continue to surround yourself with all the right people that are going to be supportive for you during your survivorship care. Many people will look at you and view you as looking well and moving on, but they may not understand that you're still struggling perhaps with some of the side effects due to treatment. And so our message right now during your survivorship care would be good communication with your family and friends, perhaps your employer, your colleagues, that although you may look well, you're still recovering and being rehabilitated from your cancer treatment. The big YOU, you in the middle, is a big part of our program, and that we're trying to give you self-management tools to empower you to really be a part of your own care moving forward. It's really important that you're an active partner in your care moving ahead during your follow-up with your primary care provider. When you're in the cancer center, a clerical team person will call you and tell you when to come in to see your oncologist. That will likely not happen once you're back to the care of your primary care provider. And the reason being is that they mean very well, of course, but they can't remember to call all their patients at certain intervals of time to come in. And so we're encouraging you to do is to be an active participant in your care, to make sure that those tests which are outlined on your care plan are completed and that you know the results of those tests. Don't assume that no news is good news. If you're waiting and wondering what the results, for example, of a mammogram are, then be proactive and ensure that you receive the results. Be aware of those written follow-up plan recommendations that are outlined on your care plan, and be proactive to ensure that those follow-up visits take place at regular intervals of time. Usually what I recommend to the patients that I see is that if you know, for example, if you need to be seen every 6 months, then what you want to do is when you're leaving your primary care provider's office, make the next appointment for when you're walking out the door, just like you would at the dentist or your hairdressers, perhaps. You want to be proactive and make sure that it happens at regular intervals of time. And also, it's convenient for you to schedule those appointments around your busy work life, perhaps, or if you have travel plans. It's really important that everybody that's involved in your follow-up care, each of them have a significant role to play with a shared responsibility, and we would once again encourage you to be an active participant in your follow-up care.
As Carrie mentioned, follow up care is about all of your health. So I'd like to take a moment to discuss other cancer screening programs in the province of Ontario. I'm going to leave the breast cancer screening as this is for women who have not had a diagnosis of breast cancer. The two other cancer screening programs in the province are for colorectal cancer and cervical cancer. The colon cancer check, like the breast cancer screening, starts at the age of 50. If you're in that age group, most of you may have received a letter to start your screening. If you've had no family history of colorectal cancer, then you do the colon cancer check, which looks for blood in the stool or fecal occult blood. You can obtain your kit from your primary care provider or even from the pharmacy. So you take a sample of your stool on 3 separate days over a 2 week period. A small smear of the stool goes on each of the windows and you label the date and time. This is put in an envelope and it's sent off to the Ministry of Health in Toronto. You will get a letter back, just like you did from breast cancer screening, whether the test is negative, and in other words, you're all clear, and that you will repeat the test in 2 years' time. Or if there's any positive on any of the windows, that you will be sent on for colonoscopy for further testing. For people who are at higher risk, and these are people who have a family member who has had a diagnosis of colon cancer. So, if, for example, a brother, a sister, a father, or mother, for example, their testing is not by fecal occult blood, but by colonoscopy. That starts at the age of 50 as well and done every 5 to 10 years or earlier based on findings. Additionally, if the family member was diagnosed at the age of, say, 55, screening would start at 40. So, latest age to start is age 50 or 10 years earlier than the diagnosis of the age of the relative. And then moving forward every 5 to 10 years based on findings. For the Ontario cervical cancer screening, so this is looking for cancer of the cervix alone, not for uterus or ovary, and this is the pap smear. Pap smears, as of 2013, started to be done every 3 years. In 2016, the cervical screening guidelines were updated, and people are done from the ages of 21 if they're sexually active through to the age of 70. So, as I said, screening once every 3 years or based on the findings of that smear. Earlier, we showed you the survivorship care plan. And on that document will be the follow up or surveillance guidelines that are recommended for follow up after a diagnosis of breast cancer. These guidelines are endorsed in Ontario and by the American Society of Clinical Oncology. The template that you'll get is what we would be using here at the Cancer Center and will be recommended for both you and your primary care provider. So, as you can see at the top of this chart, one of the most important things will be having a medical history and physical exam done by the person who'll now be following you for your breast cancer follow up. This examination and history are focused on breast cancer in terms of the history, and we'd be looking for signs and symptoms that would suggest a recurrence or side effects from your treatment. So, for example, we might be asking about any new bone pain that's there every day. It's not going away or relieved by treatment. Any new lumps or bumps, or a new cough that's not going away, or any other major changes in your health. In terms of the physical exam, it's very much like you would have done here at the Cancer Center. The focused exam for a follow up in breast cancer is looking at the breast tissue, feeling the chest wall and the breasts themselves, examining under the armpits, listening to your lungs, and actually feeling your belly. And what we're looking for is feeling the edge of the liver. The history and physical exam in the first 3 years after your breast cancer treatment is done every 3 to 6 months. And in general, for most patients, it's every 6 months if they're feeling well and doing well. In years 4 and 5, you're seen every 6 to 12 months. And then thereafter, an annual visit is recommended. However, I do want to note if you have any new or persistent symptoms that are occurring between visits, not to wait for the next scheduled visit with your primary care provider. With regard to mammograms, the recommendation is every year. The first mammogram is usually done around a year after your surgery, or we look at doing this not any earlier than 6 months after you finish radiation treatment. That's to give the breast time to heal and the changes as much back to normal as possible. For those women who have had a mastectomy, you do not need mammography on any of the skin or fatty tissue left there. The physical exam should be sufficient enough. For women who've had reconstruction with their own tissue, currently we are recommending mammography on that. If you've had implants and no breast tissue has been left after a mastectomy, those do not need to be imaged either. I always like to point out what you don't see here, and that's blood work or other imaging studies. Studies have shown that 75% of recurrences are picked up on the physical exam and history, and the rest are done by chance. So you're having a test for something else, and recurrence shows up. Current recommendations are that other tests are unnecessary and they create more stress and discomfort. And additionally, these tests should be done based on symptoms. For women on tamoxifen, we recommend a pelvic exam be done. However, the context of this is that for women on tamoxifen who still have their uterus and are postmenopausal or have finished their periods, they are to report any vaginal bleeding or spotting promptly to their primary care providers for follow up. Bone mineral density is on here, and for most women over the age of 60, we start screening with a bone mineral density. For women on aromatase inhibitors, so that's things like anastrozole, letrozole, or exemestane, we tend to do a bone mineral density about every 2 years. Sometimes you'll have one about a year after being on treatment to ensure that we're not making you lose any extra bone mass above and beyond your menopause. And lastly, we still recommend that women perform their monthly breast self examination. I'm going to let Carrie discuss the technique for breast self examination in a moment, but one of the things I do recommend is that for women who are postmenopausal, you pick a significant day in the month, whether that be the first Sunday, the first day of the month, or your birth date, and use that as your cue on a monthly basis. For women who still have their periods, the recommendation is to do your breast exam on day 5 after your period starts, as this is the time that the breasts are least responsive or affected by the hormones in your monthly cycles.
This diagram may look familiar to some of you when you think back to the time that you were newly diagnosed and meeting with the surgeon for them to describe to you how they were going to do their surgery. One of the reasons we include it in the class is to remind women that benign entities of the breast can still happen after a diagnosis of breast cancer care. So, for example, you may develop a cyst, which is a fluid-filled sac in the breast, which is completely benign and often comes around the time of hormonal fluctuations between the age of 45 and 55. Another benign entity of the breast is a fibroadenoma, which is a solid tumor but completely benign. And both cysts and fibroadenomas do not heighten a woman's risk of a development of a breast cancer or a reoccurrence of cancer. However, any lump or bump that you feel in the breast moving forward, although it may be benign, it's important to report that to your primary care provider and not wait. The other thing is nipple discharge. There was once a time when women would be encouraged during their breast self-exam to try and express for a nipple discharge. That is certainly no longer the case. If you should wake up in the morning and your nightie, for example, is spontaneously wet with either a red blood colored fluid or a clear or watery colored fluid that came out on its own, then that is the type of nipple discharge that you would want to report to your primary care provider right away. When you look at this diagram, this is a woman with her right arm elevated, and the little green peas or beans represent the lymph nodes. We all are built a little bit differently anatomically, but on average, a woman has 35 to 45 lymph nodes in each of their armpit, or axilla is often the medical term for the armpit area, in the axilla region. So your surgeon at the time of your surgery, if he or she did an axillary node dissection, on average, that means removal of 8 to 12 lymph nodes. If they did a sentinel lymph node biopsy, which is more common these days, then on average 1 to 4 lymph nodes are removed. At the time of surgery, the surgeon cannot see the lymph nodes. Rather, they take a pad of fat and it is sent to the lab with the breast tissue, and a pathologist looks under the microscope, and it is at that point that how many lymph nodes are discovered is reported on your pathology report. So sometimes women think and refer to, all of their lymph nodes being removed, but that is certainly not the case. And you have many lymph nodes remaining in the affected side. Or if you've had both breasts operated on and you had both sides having lymph node dissection, there certainly is lymph nodes that remain. The pinkish area at the top of this diagram is the muscle. And if a woman has a mastectomy, the surgeon removes the breast tissue down to the muscle area. And the muscle on the rib cage is the chest wall area. The yellowy substance is the fatty tissue and the obvious breast tissue that you feel when you're doing a self-exam. The lobules, or these purple ovals, are where the cells are housed that create milk. And of course, the tubular system in the breast is called the duct, or the ductal system, which carries the milk from the lobule. To briefly review breast self-exam, it is really important when you examine yourself that you pick a day of the month that you'll remember to do the exam. If you're a postmenopausal woman, you would choose a day of the month that is familiar to you or would serve as a good reminder, like the first day of the month or your birth date. If you're a premenopausal woman, if you are still menstruating, then you would choose a day, usually day 5 or at the end of your period, when the breast is least engorged and easiest to feel anything, to do your breast self-exam at that time. Regardless of what we hear in the media or what we hear in the community from individuals, we do recommend a woman do their breast self-exam once a month. So how do you do it? Well, many women are taught to do it standing and lying. And if you do it standing in the shower, of course, there's absolutely no harm done in doing so. But it does make feeling anything a little bit more difficult because the breast tissue falls upon itself. Best way to do it is lying down, bringing the arm elevated above your head of the side that you're going to be examining. The reason why we say it's important to do it lying down is because the breast naturally displaces itself evenly, and it makes feeling for any nodularities that are new much easier. And the reason why we recommend it once a month and not more often than that is because you need an interval of time from month to month to go by in order to objectively pick up on a change. If you're doing your examination more often than that, then what you could be feeling as in fact a change becomes normalized. And that's why we recommend it just once a month. So with your arm elevated above your head, you bring your opposing hand over and be sure to use the pads of your fingers. If you use the tips of your fingers, often what happens is that you can feel the rib or the breastbone area, the sternum, very easily. And what happens is it frightens a woman because they think it's a lump. So use the pads of your fingers and start under the collarbone. Remarkably, breast tissue does go up that high, and although we don't see many lumps as high as just under the collarbone, we do in fact see them. And so you want to be sure that you start at the top under the collarbone. Think of the breast as a wheel, with the nipple being the central part of the wheel. And then what you do is you start under the collarbone and you compress with the pads of your fingers gently but firmly along each of the spokes of the wheel, all the way around and including the nipple itself. Why the spokes of the wheel are important using a gentle compression is because you want to make sure you overlap and that you don't forget an area. Then, when you've completed both sides lying down, recall how your healthcare provider examines the armpit area when you're in the clinic. You let your arm fall down to your side, relax your shoulder, and use the pads of your fingers once again to feel along that chain of lymph nodes. And what you're going to be feeling for is any little spongy area, for example, or a pea, or perhaps it feels like a little bean. That could be an inflamed lymph node. What we would ask you to do is, if you do feel a lymph node, is wait 2 weeks. And if it's still there 2 weeks later, then you would report that to your primary care provider. Lymph nodes normally and should react to fight infection. That is their job. And so you could be fighting a flu or a cold, a virus of some sort, and your body is fighting that infection and the lymph node enlarges. But if it doesn't go away after a period of time, for 2 weeks, for example, then you would report that to your primary care provider and let them examine you so that you can get an objective opinion from them. When doing your self-examination that includes the axilla area, it's really important that women who have had mastectomy or mastectomies be aware that your self-examination is done in the same way. Use the wheel, for example, so that you're overlapping and not missing area. And like a lumpectomy, the same as a mastectomy, you want to pay closest attention to that scar area, the line in which the incision was made. You feel, for example, with a mastectomy, you want to use the pads of your fingers and rub or compress along the top of the scar, on the scar, and below the scar. And the same with a lumpectomy, because we know that if it's going to reoccur, the more common place for a reoccurrence to happen is at the original site where the cancer was first located. Also, with a mastectomy or with a lumpectomy, it's really important to examine around the surrounding areas as well. So both sides, your neck area, and the axilla area when you're doing your breast self-exam. The final part of a self-examination that sometimes women aren't aware of for both a lumpectomy or a mastectomy is that you make sure that you do a visual inspection of the skin, looking in the mirror for any visual changes of the skin. For example, a pink flush of skin that sometimes arises from the scar, redness, if you notice a change in temperature of the skin, if you notice that the breast is fuller, if you see something that reminds you of scaling skin, or if it's a blistering type effect on the mastectomy site or a lumpectomy, those are examples of what you would watch for a 2-week period of time, and if it doesn't go away, then you would report it. Sometimes you're just simply lying on your pajamas or your nightie in a certain way that causes a redness of the skin to occur. So again, you watch it for a short period of time, like 2 weeks, and then you would want to report it to your primary care provider. The last thing that I want to mention around breast self-examination is also self-examination not only of a mastectomy site, but if you've had reconstruction of the breast as well. The same thing, either using your own body tissue for the reconstruction or a saline or silicone implant. It's really important that women do their self-examination in a similar manner as they would as if the breast was there. And sometimes that surprises women. But even though a mastectomy has occurred, or if a mastectomy with a implant or using your own body tissue has occurred, we know that although the chance is extremely small, the chance does remain that a reoccurrence could develop underneath the skin, and therefore it's really important that you do your self-examination and visual inspection of the skin on a regular monthly basis. Before we talk to you about the most common late and long-term side effects due to breast cancer treatment, Gail and I would like to talk to you about the 3 common survivorship concerns that we often get asked about.
One of the common questions we often hear from women is around the concern of hereditary breast cancer, in particular BRCA1 and 2. I want to start by saying that only 5 to 10% of all cancers are due to an inherited gene. This is something passed on from parent to child, and it is not the cancer that's passed on, but a defective gene that increases the likelihood of developing a cancer related to that gene. We all share half our genes from our mother and our father. What we look for are cancers on one side of the family or the other, and across more than one generation. So, mother, mother's brother, mother's father, and his mother, for example. We also look for related cancers in that family tree. So, for breast, that would be things like breast, ovarian, and prostate. So, we also look for cancers at an early age, either in the person diagnosed or their family members. And our concern is also heightened when we have an individual who develops 2 different types of cancer themselves. I know that the first appointment at the cancer center was very busy and lots of information, but you might remember that you filled out a family history. If there were concerns at that time, you would have been referred to CHIO for genetic counseling or discussion. And really, what's important in my mind is that if there's new information between your appointments, that you report that to your primary care provider or whoever is doing your care, because this may affect a referral for genetic counseling. Additionally, one of the other questions asked is about having the children tested if there's a concern about a parent. In fact, what it is, it's the person who has the cancer or the index cancer that is tested. So, for example, if a woman was tested for genetic links of cancer, if she was negative, there would be no reason to believe that she'd passed a gene mutation on to one of her children.
A second common survivorship concern for women who have been treated for breast cancer is lymphedema. What exactly is lymphedema? Well, when you break down the word and you look at the word lymph, lymph is a colorless fluid that contains white blood cells, and it's a fluid that circulates through the lymphatic system, and it bathes the tissues and it drains through the lymphatic system into the bloodstream. And edema, when you look at the word edema, this is a healthcare word that means a swelling. And so lymphedema together is a swelling or a blockage that occurs in the lymphatic system, which prevents the lymph fluid from draining well. When you look at this green diagram, you can see that we have lymph nodes not only in the armpit area where the cancer surgery occurred, but also in many different areas of the body as well. And these lymph nodes are chambers that really fight infection and collect microorganisms. Signs and symptoms of what to look for around lymphedema include an achiness in your fingers, in your hand, tingling fingers in the hand area. There's a heaviness that sometimes women will encounter of the affected side. Change in skin texture, so sometimes the skin becomes a little bit shiny when it's swollen. A tighter bra, either the cup, because lymphedema can occur of the breast itself, and it can also occur around the back area, and so when you go to fasten the bra, it's a little bit more difficult to do so. So what can you do to help prevent lymphedema? Well, there have been a number of studies that have recently shown that maintaining ideal body weight is the most important thing that women can do to reduce the risk of developing lymphedema. And there was an increased risk shown for those who are overweight or obese. And Gail later is going to talk to you about the importance around exercise for other reasons, but maintaining healthy body weight through exercise and good nutrition is another reason to do so, is through the prevention of lymphedema. Also, exercise has been shown to not only restore flexibility and strength of the shoulder and the arm that you've had surgery on, or both sides, if both sides have been affected, but it also improves drainage of the lymphatic system. So when we think about dragon boating, for example, one of the reasons why dragon boating was first started many years ago was around the prevention of lymphedema and exercise showing its benefit to keep that circulation moving. This includes exercise in other areas as well. Walking, movement of the arms, and so on is being so important to not only reduce being overweight, but also promotion of that lymphatic circulation. Also, protection of your skin from infection. Many women are concerned when they're gardening or doing the dishes, for example, that they feel that they may puncture the skin and therefore increase the risk of lymphedema, when in fact it's not a puncture that causes an increased risk of lymphedema. Rather, it is the puncture that then becomes a port of entry for microorganisms or infection to occur, and it is the infection that can cause cellulitis or an infection of the skin, and it's the cellulitis that causes risk of a lymphedema. So if you were to puncture your finger, for example, if you were gardening, then you would want to clean that area quite well to reduce the risk of an infection developing, a cellulitis from developing, and therefore reducing the risk of a lymphedema. It's been unfortunate, really, for the last many, many years that there have been many myths associated with lymphedema. And what these myths have done is it's really promoted anxiety for women around the topic of lymphedema. And myths such as, for example, being told not to ever have a blood pressure taken from the affected side. A manual blood pressure cuff that a healthcare provider uses to manually pump up the strap to take your blood pressure is not going to cause lymphedema. And it's unfortunate that even healthcare providers have perpetuated that myth in telling patients to always use the other side. Well, what do women do when they've had both sides affected, for example? The blood pressure cuffs that we want you to avoid are the blood pressure cuffs that are automatic. For example, those automatic cuffs that you see in the drugstore or in Walmart, for example, or the ones that are in hospitals that healthcare provider puts on and then perhaps they walk away and the cuff continues to increase in size. And what happens is there's risk of damage to the lymphatic tubular system that could perpetuate a lymphedema risk. So you would want to avoid that. Another myth is blood procurement from the affected side. It is okay to have blood procurement drawn from that side. You would just want to keep the puncture site clean. But otherwise, there is no risk of causing a lymphedema or heightening the risk of lymphedema from blood procurement from that side. However, having said all that, if you're the type that is going to worry about it and it will wake you up at night, then the other option is either to put out the other arm, if that's an option for you, to have blood pressure or blood procurement from the unaffected side. And therefore, you can rest assured that if lymphedema ever occur, then, it's nothing that you have done. However, we can repeat by saying that the one thing that the research has shown to increase risk of lymphedema is obesity and being overweight. And therefore, it is just another good reason to maintain healthy body weight to reduce the risk of lymphedema from occurring. The last thing I just want to mention is around sleeves. And sometimes women are advised to wear sleeves when they're going on a long haul flight. And what has been found is that if you have not had lymphedema and you go on a long haul flight, with the cabin pressure increase, what can happen is the limb can swell. And if the sleeve is on the limb, and can act like a tourniquet and prevent normal flow from occurring, it is not advised to wear a sleeve because it could cause some damage for the affected side. The other thing is that what we have found is that women who do have lymphedema and that do wear their sleeve during a long haul flight, it in fact causes more swelling to occur because that natural circulation can't occur as freely with the sleeve being on the arm. So should you have any further questions around lymphedema or any further concerns, talk to your primary care provider or one of the nurses in the Wellness Beyond Cancer program, and we can help hopefully alleviate some of the concerns that you may have. A third common survivorship concern that we get asked about is around breast reconstruction. Breast reconstruction is not performed by the general surgeons who do your breast cancer surgery, but rather by plastic surgeons who have an expertise and specialized training in breast reconstruction. Some things that we want you to be aware of is, first of all, breast reconstruction, regardless of the interval of time from the time of diagnosis, end of treatment, or through survivorship, is OHIP covered. OHIP also covers the unaffected side should the plastic surgeon discuss with you the possibility of doing a lift so that the unaffected side is in symmetry with the breast reconstructed side. There are different types of reconstruction that the plastic surgeons can use and will discuss with you. Is first of all, implant reconstruction that's either an implant filled with saline or salt water or silicone gel. Also, if your body is the type that plastic surgeon feels would be okay to use your own tissue, then the tissue would come from either your belly, your buttock, or perhaps your back. Also, plastic surgeons have started to do reconstruction of the nipple, that being visually through a tattoo or made by your own transplanted tissue. So something to think about and something to talk to them about. Other considerations that are important is really realistic expectations to have around the outcome of the surgery. We know that the breast reconstructed area will never feel like it did originally before your breast cancer surgery. However, wearing a bathing suit, or if you have a bra on, nobody would ever know that the breast has been reconstructed. And so women will often feel good about that appearance, feel more balanced or more symmetrical. It's a very, very personal decision. What we have found is that there are many young women that say, I've been through a lot. I'm not interested in going through anything further at this time. They have a young family. They don't want to have any further recovery. And so breast reconstruction is not for them. However, we get elderly women who are having difficulty perhaps with balance or getting their clothing to fit, and for their own personal reasons feel that yes, they want to move ahead with perhaps having breast reconstruction. Our message is whatever is best for you, we would recommend that you request a consult with a plastic breast reconstruction surgeon. Sometimes the waits are lengthy. And so if you're even considering it, ask your primary care provider or the nurse practitioner within the Wellness Beyond Cancer program to send you for a consult. You can withdraw the consult if you decide to before you ever meet the plastic surgeon. However, if you decide to go and have the consult, it's great because you're getting information from an expert in the area so that you can take that information home and make a personal decision that is best for you. Sometimes the plastic surgeons will have in their office photographs of their really good work and maybe not so much their good work. And so you can ask to see their photographs around what you can expect an outcome to look like. And this really, having a visual really helps women with their decision making, should that be good for you. So Gail and I would now like to review with you the most common late and long-term side effects due to breast cancer treatment. And when we talk about treatments, what we're referring to is either late and long-term effects that could occur from the surgery, that could occur from chemotherapy, or could occur from radiation, or perhaps all of the above. What are late and long-term side effects? What do we mean by that? Well, there are a broad range of physical and or psychosocial effects due to cancer and its treatments. And what we find is that the severity ranges from person to person. What affects one person may not affect another, even though the treatment may be identical, or if it does affect another person, the severity of that effect may be very different from another person. A long-term effect, what does that mean? Well, just that. It's a side effect that occurs during treatment, and then once the treatment ends, the side effect lingers or persists beyond the end of treatment. For example, a side effect might be peripheral neuropathy. The treatment ends, but the neuropathy may continue for a period of time. A late effect, on the other hand, is a side effect that occurs after a treatment has been completed. So the treatment ends, a period of time goes on, and then suddenly you may develop a side effect. An example of that may be depression. If you're feeling tired at the end of your cancer treatment, well, you're not alone. Fatigue continues to be the most common side effect of cancer treatment, and it's been reported across all disease sites as being the most distressing side effect of cancer treatment. So what is a cancer-related fatigue? Well, it's a profound tiredness that isn't relieved by rest or sleep, and patients describe it very often as being paralyzing. And it's also been described as being very frustrating as well. Just when you're trying to move on beyond treatment and resume your normal activities, perhaps go back to work and so on, it seems to be a reminder of the cancer treatment itself, and it can be very frustrating. So what can you do? The first thing is sleep hygiene. Those are fancy words that just mean all the motherhood statements that we're aware of and learned early in life. For example, sticking to a sleep schedule, going to bed at the same time and waking up at the same time, even on the weekend. If you don't fall asleep right away, to get up for a few minutes and then try again. Or if you wake up through the middle of the night, you want to use the washroom, move around a little bit, perhaps for 15 minutes. And once you're feeling tired again, then to try and go back to sleep. Also, patients have told us that having a bedtime ritual can be very helpful as well. For example, reading a book, listening to soothing music, a warm bath, and patients have also described doing yoga type stretches as being very relaxing and very helpful for sleep as well. Making sure that your room is comfortable, that the lighting is proper, that there's room darkening blinds should you require those in your bedroom, and making sure that the bedding is cozy and comfortable, that your pillows and bedding are right for you, not too hot, but also keeping you warm as well. Something that's also important is to limit daytime naps. Sometimes people with cancer-related fatigue require a nap through the day, and it's finding that right balance of activity and rest. But if you're going to sleep in the afternoon, try not to sleep for too long, because it could make a difference in you being able to get to sleep and stay asleep at night. Gail's going to talk to you later around the importance of activity and exercise. And again, I'll mention that exercise is a recurrent theme throughout our education session. And exercise has certainly been beneficial for patients with cancer-related fatigue. Other things are also acupuncture, meditation, and yoga. Yoga is becoming clearer in the research as being beneficial. And who would have thought that intuitively that something that could relax you could actually invigorate you and be helpful with a fatigue? Think about the foods that you're eating. Food fuels our body, and therefore you want to fuel it with all the right nutritious foods, and also keeping hydrated and ensuring, particularly in the summer months, that your body has the hydration that it requires, because it could make a difference in your fatigue levels. However, if these general strategies don't work, we would encourage you to speak to your primary care provider. We can't always assume that the fatigue is related to the cancer treatment, that there could be other things that need to be investigated. For example, an anemia, your iron stores are low, your hemoglobin is low, or ferritin is low. Ferritin is where iron is stored, for example. There could be something with your thyroid that needs to be investigated. When patients have a low thyroid, for example, then they feel often very tired. In diabetes, one of the symptoms of diabetes is fatigue. So it's always really important to report any other concerns or persistent nagging fatigue after the general strategies are utilized to your primary care provider to rule anything else that could be going on out. The next slide I'd encourage you to listen to is a video by Dr. Mike Evans, and he talks about some strategies that patients who are treated for cancer can use to help manage their fatigue levels.
Hi, I'm Dr. Mike Evans, and I have a quiz for you. I want you to guess what the most common medical issue is for people on the cancer journey. Maybe pain, or depression, anxiety, lost appetite? Turns out the biggest complaint in people with cancer is fatigue, tiredness, exhaustion. It's important for you and the other people in your life to know that fatigue in cancer is partly normal fatigue, the fatigue you had before you had cancer, getting tired, coping with specific health problems, and so on. Then layered on top for the majority of people with cancer, but not all, is a fatigue that is different, that we don't totally understand, but seems to come with the things that come with cancer: harsh treatments, stress, travel, the cancer itself. A fatigue that is different than normal fatigue, as it tends to last longer and is not relieved by rest and a good night's sleep. As one of my patients said, "My brain says go, my body says no." Fatigue and cancer are two words with a lot of meanings. We humans have many different types of cancer. We will all have variable outcomes, severities, treatments, so it's very difficult to generalize, and there's not a one-size-fits-all strategy here. Having said that, I think there's a massive opportunity to make progress on a pervasive symptom that you and I too often take for granted. Fatigue, like pain, is a self-perceived state. Patients often describe it as a sensation of exhaustion during or after usual activities, or even a feeling of inadequate energy to actually begin these activities. With cancer, people often refer to a new type of fatigue that is a whole body experience. This is why it's so important we pay attention to fatigue. Our energy level permeates so many different aspects of our lives. Our mood, our work performance, how we socialize, our sense of self-confidence. So to put a positive spin on this, I think taking care of your fatigue can actually treat many other important aspects of your life. A trial led by Karl Reif and his colleagues published in 2012 is a good example. 261 German patients with 29 different types of cancer were divided into two similar groups. Most of these patients had a high symptom burden, exhaustion, anxiety, pain, and so on, and many had already tried something to alleviate their fatigue. All participants received a general lecture about cancer-related fatigue, and then one group were put on a waiting list. The other half divided into groups and met once a week for 6 weeks. The investigators felt that just knowing what to do wasn't enough, so they focused on helping the patients improve their skills in positive change, what we call self-efficacy. In the sessions, there was lots of discussion between patients, and participants were encouraged to keep a diary to reflect on the experience, exercise, and make lifestyle changes. When they compared the waiting list group to the group that met and discussed their experiences, they found the latter group exercised more and felt more confident about making good things happen. This translated into significantly less fatigue, the main focus of the trial, but also less depression, anxiety, increased quality of life. I think the message from this trial is it's one thing to hear from people like me that you need to exercise or reduce stress, but it's another to problem solve, set goals, reflect, and be supported by people who are facing similar challenges. Research shows up to 90% of people with cancer experience fatigue. It's very difficult to point to one mechanism. There are so many things going on. The treatments can be toxic, your body is repairing itself, altered nutrition and sleep cycles, stress and travel, and of course your emotional state can be a major influence on the severity of fatigue. Patients who are older, who have advanced cancer, and who have received more than one type of treatment, such as radiation and chemotherapy, are more likely to have long-term fatigue. One reason that fatigue is undertreated is there is no high-tech test. Western medicine is much better at treating things it can test for.
Having said that, a good way to describe fatigue to your caregivers is to give yourself a score on a scale of 0 to 10, where 0 means you don't feel tired at all, and 10 means the worst tiredness you can imagine.
If you're scoring above 4, you need to discuss this with your caregiver. If you're scoring above 7, you really need to. Another reason for undertreatment, which is interesting, is that people don't bring up their fatigue with their care team, as most believe there's nothing that can be done. So with that in mind, the question is, what is the most effective treatment? Well, it's interesting, is I would say the best treatment for most of fatigue is, well, actually, you. Yeah, sure, you may need to treat your anemia, your thyroid, or the side effects from medications, but even then, I think you'll gain strength if you improve your own thoughts, attitudes, and behaviors around fatigue. Looking at the research, my take is that there are 2 key behaviors that we see in people who manage their fatigue well. So let's start with what I would say the research shows is the number 1 treatment for fatigue. Exercise, activity, walking. Now, this is, of course, counterintuitive. I actually feel weird saying it, as I have this reality check image in my head of you being up all night sick or just coming out of surgery and going, really? And obviously you need to fuse the research with your own reality. But when patients ask, won't that exercise or activity make me more tired? Actually, the research says no. There's significant evidence that a low to moderate intensity exercise program can substantially reduce cancer-related fatigue and improve your quality of life. You're going to have to figure out for yourself what is the amount of exercise that energizes you and what tires you. Most trials start with half an hour a day. You can take your pick: walking, low weights, yoga, cycling, waving your arms in bed, whatever works for you. No specific form of exercise has been found to confer greater benefit than any other. Many patients find it helpful to track their activity with a pedometer or one of these new fancier electronic versions. Also, let's face it, cancer can put that 3 pounds of brain tissue that controls our levels of fear, joy, worry, sadness, and our sense of control through the ringer. And I think walking does a lot for mission control. The second key, and this may be a good life lesson for all of us, is to visualize your energy bank account. Now, many of you will find that your energy account is less with cancer. So you need to look at the things in your life that draw on that account. Stressful relationships, worry, pain, sleep problems, and counterbalance these with healthy eating, meaningful work, reframing of setbacks, humor, and peace of mind. It's time to stop and push the reset button. What in my life is needlessly subtracting from my energy account, and what can I do to add to it? To keep the energy account in positive balance, we often talk about the 3 Ps: planning, prioritizing, and pacing. Planning fatigue management around treatments is critical. Almost 100% of people experience fatigue with cancer treatments. But how much you will is hard to know. For radiation and chemotherapy, this fatigue tends to get worse with successive treatments. Fatigue with surgery is so dependent on the type of operation, but most people do get better with time. Expect that it might take 2 to 3 months for fatigue levels to return to normal. For some, the road back to normal can take even longer. Your care team can help you plan for fatigue. Interestingly, research shows that general cancer coping programs aren't nearly as successful as fatigue-specific programs. A large review showed general programs were successful 14% of the time, and fatigue-specific programs 80% of the time. Typically just 3 sessions focusing on education, self-care, coping strategies, and activity management. Many cancer centers offer these programs, so sign up and don't forget to ask other patients. There's a lot of practical wisdom out there. Priority setting is critical. Having cancer can give some clarity to this. Draw a picture of your major commitments, consider where each fits on your list, then talk to the people involved to manage expectations and get a shared vision of what the new plan is. Now is the time to redesign your week around your priorities. Keep it simple: nutritious food, good sleep, good friends, and finding a place where you can visit that brings you peace. Healthy eating is both more important and can be more of a challenge with cancer. Patients often reflect on how they need to be more thoughtful about their nutrition when starting treatment. That making change in their calories, protein, or fiber intake can give them much more energy. Pacing is key, especially for people that are used to being able to go at a high rate all the time. Pacing is linked to priorities, but plan for things to take a little longer. I find pacing can also be about attitude. You're going to walk a fine line here, both with cancer and with fatigue. Being optimistic, but also realistic. Hoping for the best, but preparing for less. Being active, but not overdoing it. This will require special powers from you, I think, in being adaptive, flexible, and giving yourself time to process. All these self-care skills are much improved with a favorable attitude. Easy for me to say, but something to think about. I'll finish by repeating myself. Discuss fatigue with your care team. Discuss it with important people in your life. Don't be scared to ask for help, and maybe more importantly, take it when it is offered. Try and be active, eat healthy, plan and pace. You are the medicine for fatigue. So I hope this helps. Take care.
Some chemotherapy causes a side effect that we call peripheral neuropathy. These symptoms are caused by damage to nerves that are the furthest away from the brain, and in particular, we talk about the feet and hands. These symptoms happen on both sides in the same way, and I often call this the stocking and glove effect. So patients often will talk about it being like having 2 socks on and 2 gloves, and that's typically the areas that are affected. Peripheral neuropathy is most often either pain, burning, or tingling, and even numbness in the hands and feet. These symptoms start during chemotherapy. They can either be short-lived or can linger for quite a length of time. However, we know that they don't go away right after the chemotherapy. So in that first month after chemo stops, it may start to improve, but often lingers quite a bit longer. We know that it often gets better in reverse order. So as I said, it'll start in the feet and then it may progress to the hands. And as that happens, it reverses the other way. So the hands get better first and then the feet. Often I've heard patients say that they can't do up their zippers or their buttons with their hands, and that's what improves first, for example. As you can imagine, the issues that will happen, especially if you've got numbness or no sensation in your hands and feet, are about safety. So care needs to be taken with sharp objects or preventing slips and falls. Additionally, people will talk about it being exacerbated by triggers such as heat and cold. So, for example, even if people don't feel that they've got the neuropathy anymore and it's resolved completely in the cold weather or in the heat, they may have some increase in some tingling or burning in their hands or feet. There have been things that have been tried, and things such as massage, acupuncture, or nerve stimulation have been used to help reduce or reverse the peripheral neuropathy. Vitamin E and vitamin B complex and B12 in particular have been used to help peripheral neuropathy as well. In particular, we've had a number of people use acupuncture to help with reversal of their peripheral neuropathy and have had some good success. For patients who have pain or burning, often they may need medication. So it may be B12 because there are some conditions such as pernicious anemia, which is a low B12 that may be needing to be treated. But however, for people who have had peripheral neuropathy due to the chemotherapy, there are some medications that we can use, especially when there is pain involved. So there are some anti-seizure medications that we've used that will help with the burning and tingling, and other pain management may be required. However, if the peripheral neuropathy is continuing or it's new onset and you've finished chemo quite some time ago, we would encourage you to speak to the healthcare provider or your primary care provider about medications and further testing to ensure that there's not something else going on. For people who had chemotherapy that might affect heart function, you would have had the tests before looking at the valves and the heart strength. In most cases, heart function returns to normal even if it is slightly affected. But where we get concerned is even in the long term, you have a new onset of shortness of breath, a rapid or irregular heartbeat or what we call palpitations. Someone develops a new cough at night, or indeed needs to use now 2 or 3 pillows instead of 1 pillow to sleep appropriately. And in some cases, patients might say, I now need to sleep in the chair. Additionally, one of the other signs and symptoms we'd be mindful of is if we have swelling in both feet and the lower legs, so we're holding that extra fluid. And certainly we recommend you seek earlier attention than a regularly scheduled visit if you start having any of these symptoms, and certainly seeking more urgent attention if you're having chest pain or sudden onset shortness of breath. However, we need to maintain our cardiac health not only from a cancer perspective, but certainly from our overall health. So we do recommend exercise, starting slowly and ensuring that you're able to exercise and get clearance from your healthcare provider. Seeking any attention for those new or persistent symptoms, as I said, maintaining one's body weight and keeping that in check. Certainly, smoking cessation is an important piece of maintaining our cardiac health. And as we said, it's the rest of our health that's also important now. So ensuring you have regular blood pressure and cholesterol and blood sugar checks. Chemo brain or chemo fog is a common term used to describe thinking and memory problems after cancer treatment. Patients often describe a decrease in mental sharpness and are often worried about things like dementia. Studies have suggested that we know there is more than one cause for these cognitive changes. There can be other causes such as fatigue, depression, sleeping disorders, change in hormones, nutritional status, for example, and even stress. However, we have seen this occur during chemotherapy, and it can last either a short time or others find that there's a longer interval where they're finding it difficulty in multitasking or concentrating or learning new things. As I mentioned, the common concern for patients is whether or not they have a dementia that's developing. I'd like to state that if this is a concern that you have, I'd like you to bring it to the attention of your primary care provider or your provider here. There are quick screening tests that can be done to help rule in or rule out a dementia that may be occurring. I know that when this has been done for our patients, we can put their minds at ease and then work on the issues around any of the cognitive changes they're feeling due to their chemotherapy or hormone therapy, for example. We know that there are activities that will help the chemo fog, such as rest and relaxation, good sleep, and nutrition. There have also been studies that have demonstrated increases in physical activity and movement have helped cognitive issues, as does going back to regular routines and habits such as lists and notes and use of calendars. For those people finding it difficult to learn, we know that avoiding distractions is quite important. Additionally, a couple of suggestions with regard to brain games. So these are computer games such as Lumosity or Elevate.com, which will do some learning things, whether it's attention or memory. And as we often hear, things like Sudoku or puzzles and crosswords will also help thinking and concentration. For some women, treatments make menopause come early. For others, our treatments such as tamoxifen or the aromatase inhibitors, anastrozole, letrozole, or exemestane, give side effects that mimic the symptoms of menopause. As you can see, there's quite a shopping list of signs or symptoms of the menopause, and we know the intensity and duration of the symptoms vary from person to person. We have people who say they have none to very few side effects, to those that these interfere with not only their sleep, but their activities of daily living. There are many ways to manage some of these symptoms. We often talk about tracking triggers, so sometimes we'll ask women to diary their symptoms, time of day, and when they occur from the time they take their medications. But we also know that things like stress, hot drinks, spicy foods, and alcohol can actually trigger hot flashes for some women. Also, talking about dressing in layers and not using synthetic materials are important. For some women, dietary changes are really important. Some women find when they're having fatty foods, they have an increase in hot flashes. We also know that smoking increases the intensity and duration of menopausal symptoms, and one of the strategies is to cease smoking. Additionally, we know exercise lessens hot flashes, so the recommendation for about 30 minutes per day, even walking, might help decrease the intensity or duration of hot flashes. There is some evidence that things like yoga, meditation, acupuncture, and relaxation techniques are useful in either relieving or eliminating menopausal symptoms. However, if these usual techniques don't help and your symptoms are quite worrisome and bothersome to your daily activities, talking to your primary care provider, or if you're followed here, us at the Cancer Center, there are a number of medications that we can try. So some of these are old blood pressure medications, and some of the antidepressants at a very low dose are quite effective in relieving or minimizing side effects from these medications. Osteoporosis or osteopenia are the terms used for a decrease in bone mass or bone strength. This is an issue that happens for both men and women as we age. In women, as we hit menopause, this is often due to the decrease in circulating estrogen, and we stop laying down as much bone as we did earlier. In the context of breast cancer treatment, there are a number of reasons that will increase the risk for osteoporosis or osteopenia. This is because we reduce the estrogen more with some of the medications we give, such as the aromatase inhibitor, and for some women, we actually put them into early menopause. As you can see, there are risk factors for the normal population, and these are things that we would monitor normally in primary care. Osteoporosis, or its precursor, osteopenia, are known as the silent thief. That's because there's really no pain or indication as you're walking around that anything is going on. Really, it's the fractures or traumatic fractures where there's a fall that's insignificant and we break a bone that often this is detected if you haven't been monitored earlier based on risk. Additionally, one of the symptoms that we'll use in primary care is a decrease in person's height so that they're actually becoming shorter. So not only do we need to talk about improving or maintaining our bone health for the regular population as we age, we also need to talk about it in context of women put at risk from our treatment with breast cancer. So first and foremost, we want to ensure that women get enough calcium and vitamin D. The current recommendations for vitamin D through Osteoporosis Canada is between 800 and 1,000 international units daily. This can be taken in the form of a pill or D drops, so they're the drops that you put on your tongue. And in terms of calcium, the current recommendation is 1,200 milligrams of calcium daily. The recommendation is to get most of our calcium via our diet. 1,200 milligrams of calcium is the equivalent of about 3 servings of milk. So in other words, that's a large serving or a regular serving of dairy at every meal. There are some great calculators on the osteoporosis.ca website. However, the equivalence, for example, is a cup of milk, a cup of yogurt. Calcium is also found in the dark leafy greens, items such as tofu and almonds. If there is a concern about the amount of calcium being taken in, some women will supplement with a 500 milligram tablet of calcium once daily, or some women will use Tums, and if they're not having a serving of dairy, take 2 Tums, which is approximately 300 milligrams of calcium after or before their meals. One of the other ways to help increase bone strength are weight-bearing exercise, things like walking, playing tennis, dancing, weightlifting. Anything that pulls on the bone helps it become strengthened. Smoking is a risk factor for osteoporosis and osteopenia, and therefore for women who smoke, we recommend, if possible, to stop smoking or undertake a smoking cessation program. Additionally, the dark cola beverages have been implicated in decreasing bone mass. So it's the things like Coke, for example, because it binds with the calcium and phosphorylates it. Additionally, if osteoporosis is an issue, there are medications we can use to increase bone mass, and these are medications called the bisphosphonates. So some of them you may be familiar with, names such as Fosamax, for example. Use of these medications are done in cooperation or consultation with your primary care provider. Since we've been giving this class, there were a number of things that women asked, and they wanted to talk about some of the side effects that occur with their endocrine therapies. I'm just going to highlight a few on this slide. With the drug tamoxifen, and it also has a sister compound that's used occasionally, Avista or raloxifene, are a couple things that women find quite often. One of the major things is vaginal discharge. So this discharge should be odorless, usually yellowish or whitish in texture, but a lot of women, because the discharge can be quite significant, will use panty liners. Problem is that a lot of them will use menstrual liners, which are meant for blood, and these can irritate the perineum or the tissues down on their bottoms. So we recommend trying to use a liner that's meant for incontinence to prevent the rash to your bottom. Avoid the use of scented products as well, and this should relieve these symptoms. The other thing that women find on these medications are that they have significant leg cramps, so those Charlie horses that occur in the middle of the night. Things that happen with leg cramps, we often talk about making sure we stay hydrated, stretching, and massage. But certainly increasing potassium and magnesium in the diet is quite useful. Foods that do that are things like bananas and dried apricots, avocados, and raisins, for example. If the leg cramps are persistent and bothersome, please speak to one of your healthcare providers so that we can ensure that there's nothing else going on. Sometimes an addition of magnesium to the diet in terms of a supplementation is also warranted. With regard to the aromatase inhibitors, there are a few issues that come up quite constantly for women with breast cancer. One of it is the joint pain or the arthritic pains that might occur particularly early in starting these compounds. If you can, taking anti-inflammatories can help, and anti-inflammatories are compounds such as ibuprofen or naproxen. My only caution is if you have high blood pressure or on blood pressure medications to ensure that you could take these intermittently with your medications. We also know that exercise and movement helps that stiffness in the morning. A lot of women report that they're a little bit Tin Man-like first thing in the morning, but as they get up and roaming around the house, they feel much better. The other big issue that happens with the aromatase inhibitors is the vaginal dryness or discomfort during intimate activities. We talk about using vaginal moisturizers, so this is something used on a more regular basis. Women used to use Replens quite a bit, and that's quite fine. We're finding now that a lot of women are switching to vitamin E, and this is also recommended by our menopause clinic. So the vitamin E is a gel capsule. You take the capsule and put it in the vaginal canal as you go to bed at night. It will melt, and if there's anything left over, it will come out in the toilet as you urinate in the morning. Often people will start doing this, 5 to 7 times, so every night for the first week or so, and then go to alternate nights. And we've seen quite a bit of success with this method. We also recommend that women use lubricants during intimate activity to ease the discomfort during sexual intercourse.
Some patients feel happy when they're transitioning at the end of active treatment away from the cancer center and back to their primary care provider. However, there are some people that feel lost, vulnerable, apprehensive, alone perhaps, when they're transitioning away from the cancer center and out to the community. We've talked a lot about the physical side effects due to a diagnosis of cancer and cancer treatment, but we're now going to talk about some of the common psychosocial side effects due to cancer treatment. Depression. Some people are somewhat surprised that after all that they've gone through, to realize that depression could occur to them. What is a cancer-related depression? Well, it's when feelings of sadness are strong and a person feels for at least 2 weeks or longer a depressed mood and a loss of interest or pleasure in activities that they previously and usually enjoyed. Some causes of depression could include chronic pain or fatigue, changes in your body, perhaps side effects like hair loss or sexual problems, feelings of a loss of what your life was like before you were diagnosed with cancer, feeling isolated, and also if you've experienced a depression or an addiction before your cancer diagnosis. There are a number of signs and symptoms that are listed here on the slide around depression, and we would ask you to look at this list of signs and symptoms. And if you can identify that you're experiencing 4 or more of the following symptoms, then that is an indication to yourself that you should report that to your healthcare provider. The second sign or symptom that's listed here, feelings of hopelessness or guilt, is often referred as a hallmark sign of a depression. And so if you can identify that symptom as one that you're experiencing, then that would be an indication to reach out, ask for support and help, and speak to a healthcare provider about the feelings that you're experiencing. A few helpful strategies to help with depression include finding support from those family and friends who are supportive, talking to someone you trust, focusing on things that make you feel better, such as doing activities you enjoy and spending time with positive, happy people and avoiding those who are perhaps negative and avoiding things that cause you particular stress. It's also important to eat well. A balanced diet can help you feel more energetic and positive, improving your sleep habits, and also exercising and taking care of your body. Life is precious, and we want you to feel as best as you possibly can. So if these general strategies are not helpful, we would really encourage you to reach out to a healthcare provider to receive the information and help that you need and so deserve. A final message is that if you are thinking about harming yourself, to call 911, go to your nearest emergency room right away. Fear of recurrence. This is another common side effect that we see at the end of cancer treatment. And as this quote by Kay states on your slide, what we have found is that as normal checkups start to come and go, what happens is that the fear and the apprehension will start to subside, at least until it reaches manageable levels, and sometimes it even disappears. What can you do to help with the fear of recurrence? Well, remember talking about the care plan and the importance of those regular interval checkups? Well, what we find is that if patients are following the guidelines set out on their care plan and are being seen by their care providers on a regular basis, it makes them feel like they're more in control and they're doing what they can do to ensure that everything is okay. And what happens is that the fear starts to subside somewhat. Be aware of when to seek medical attention. A lot of what this class is around is about knowing when to seek medical attention. So being proactive and reporting any signs and symptoms that are concerning to you will help start to manage that concern or fear that you have. Consider also what works well for you. What works well for one person may be very different than another person. Some people find relaxation techniques such as knitting or journaling or counseling as being very beneficial to help with the fear of recurrence. Other people, it's more strenuous activity like more vigorous exercise like downhill skiing, running. It's whatever you can do that is pleasurable and what you find is helpful to manage this fear that you have. Another thing that we have found is that support groups, although they're not for everybody, and we recognize that, what we have found that some patients who may be skeptical in the beginning will try a support group, and what they find is that it's very beneficial to speak with other people who have gone through what you have gone through and have a good understanding of what it was like to walk in your shoes. Also, eating well and exercise, again, those recurrent themes from this class that can also be very beneficial to help with the fear of recurrence as well.
We've talked about the fear of recurrence, but I'd like to switch gears now and talk a little bit about the things that we can do to influence outcomes and help reduce the risk not only of recurrence, but of our side effects and generally improve our overall health. As I've noted here, there are some things that we can't change, like our age, our family makeup, our gender, but there are some things that we can do for our overall health. Over the next few slides, I want to talk about healthy lifestyle and, in particular, diet and exercise. The document at the bottom of this slide, Nutrition and Physical Activity Guidelines for Cancer Survivors by Rock and Company, can be found at cancer.org and is a great general reference with regard to exercise, diet, and other lifestyle issues and its effect on recurrence and overall health. The literature has no evidence to support any specific diet after a diagnosis of cancer, and in general, the recommendations are the same as we'd see in the Canada's Food Guide, heart and stroke recommendations for a healthy heart. So that's a well-balanced diet with about 20 to 30% of fats, 40 to 60 of carbohydrates, and protein at about 10 to 30% of our caloric intake. The focus in the Canada's Food Guide and certainly this recommendation on nutrition and physical activity is focusing on healthy carbs, whole grains, diets based in fruits and vegetables, and legumes. Additionally, the recommendation is to lean away from the saturated fats and diets that are heavy on red meats and processed meats. As you can see, there are some recommendations in terms of diets high in vegetables and whole grains, showing an overall decrease in mortality for patients from all causes. There is also convincing evidence that obesity is associated with an increased risk of breast cancer recurrence, as well as influencing other causes of death. One of the studies actually showed that a decrease of 4% in body weight, which was about 6 pounds in the study, lowered the risk of breast cancer recurrence by 14%. The next slide will show a video that discusses some of the overall benefits of exercise in regard to side effects that we've discussed, as well as the overall health benefits of exercise.
Hi, I'm Dr. Mike Evans, and welcome to this visual lecture I'm calling 23 and a half hours. So I have a big interest in preventive medicine, which can mean a lot of things from, cancer screening to eating more fiber to having a good social network, and I mean that in the old sense of the word. Weighing less, drinking less, smoking less, controlling your blood pressure, cholesterol, and so on and so forth. So all of these things are incredibly important, and I wouldn't want you to minimize your efforts in any one category, but I want to know what comes first. What has the biggest impact? What has the biggest return on investment? What makes the biggest difference to your health? So I did my research and I found an answer, at least for me, and it's tricky because, all these things are sort of overlapping. But I picked out this intervention and because of its breadth, it worked for so many different health problems, and that's what I found so cool about it. So just to kind of walk you through a quick list. So this intervention in patients with knee arthritis who receive 1 hour of treatment 3 times a week reduced their rates of pain and disability by 47%. In older patients, it reduced progression to dementia and Alzheimer's by around 50%. For patients at high risk of diabetes and coupled with other lifestyle interventions, it reduced progression to frank diabetes by 58%. Postmenopausal woman who had 4 hours a week of the treatment had a 41% reduction in the risk of hip fracture. It reduced anxiety by 48% in a big meta-analysis. Patients suffering from depression, 30% were relieved with low dose, and that bumped to 47% as we increased the dose. Following over 10,000 Harvard alumni for over 12 years, those that had the intervention had a 23% lower risk of death than those who didn't get the treatment. It's the number one treatment of fatigue, and of course, the kind of outcome of choice there, my favorite outcome is quality of life, which is really all of the above and really about making your life better. And this treatment has been shown over and over again to improve quality of life. So the question is, what's the medicine and what is 23 and a half hours? So the medicine was exercise, mostly walking, so not triathlons. And let me just put it a different way. I think what I'm asking you to do is, if you think about your typical day, so there's 24 hours, and so you might spend most of your day, this varies obviously, but couch surfing, sitting at work, obviously sleeping. And what the evidence that I'm going to show you kind of tells me is the best thing you can do for your health is to spend half an hour being active, maybe an hour, and that if you can do that, you can realize all the benefits I've described in the previous slides. So let's just take a quick walk through some of the literature. So Stephen Blair, he's a professor at the Arnold School of Public Health at the University of South Carolina, and he looked at this in what's called the Aerobic Center Longitudinal Study, which followed over 50,000 men and women over time. And along the left side of this graph is something called attributable fractions, which is a kind of fancy word, but it's the estimate of the number of deaths in a population that would have been avoided if that specific risk factor had been erased. So for example, turning a smoker into a non-smoker or a couch potato into a daily walker. And along the bottom is the typical risk factors. You can see the hypertension is incredibly important and so on and so forth. But the one that kind of applied the most risk was this sort of mysterious CRF, which is cardiorespiratory fitness, which is really low fitness. So low fitness was the strongest predictor of death. And this is important. Most of the trials we see, to be honest, are funded by pharma or other companies because they've got a drug for hypertension or high cholesterol or diabetes, and we rarely see fitness thrown into the mix. And so it's nice to see a trial that's not so siloed. Blair's work is interesting. He also did another trial looking at obesity. What he found was, sort of two things. One is obesity and no exercise. That's a very bad combination, and that's where we saw many of the negative consequences of obesity from a health point of view. But if the obese person was active, even if they didn't have the weight loss, but were just active and obese, that was much, much better, and that the exercise ameliorated much of the negative consequences of obesity. So if exercise is a medicine, what's a dose? So when I think of dose, I think of how long, how often, and how intense. I'm going to give you a slightly mixed message, but essentially more activity is better. But I must say the rate of return seems to decline after 20 or 30 minutes a day. So if you're being active less than 150 minutes a week, or more if you're a kid, an hour a day if you're a kid, my flag goes up in the clinic. So my personal take on this is that the literature draws a very broad brush, and so we see big differences when somebody goes from not doing anything to doing something, and after that the return is more granular. So if we took the Nurses' Health Study, women who went from zero activity to just 1 hour a week reduced their heart disease rates by almost half. So you can break it down, so it can be 10 minutes, 10 minutes, 10 minutes if you want to do 30 minutes of exercise, so it can be broken into 3. higher intensity. It looks like it's equivalent to less time with lower intensity. But I think obviously the clinical pearl is mostly thinking about your style and habits and your personal cues. So if you're only going to do it if it's pre-booked with friends, I have couples that take a half-hour walk every morning or evening to organize their life. A dog is a great walking coach. The data is showing 67% of dog walkers achieve the 150 minutes a week just with the dog walking. And finally, of course, your commute, getting off stop early, taking the stairs, and so on and so forth. So thinking about that, I'm just going to walk you through some quick slices of the literature. The first one comes from Japan. In the 90s, Japan required all employers to conduct annual health screenings for their employees. And so a large gas company in Japan called Osaka used this to answer a great question. So if people's walk to work was longer, did that reduce their chance of serious health problems? So in this example, high blood pressure. And what they found is under 10-minute walk, no difference. 11 to 20-minute walk, 12% reduction in rates of high blood pressure or hypertension. And over 21-minute walk, a 29% decrease in rates of high blood pressure. So the authors calculated that for every increase of 10 minutes in your walk to work, there was a 12% reduction in the likelihood of getting high blood pressure. The second exhibit is looking at stents. So this is something we commonly do down medicine. So you can see on the left here, the artery's blocked. On the right, a vascular surgeon's gone in and put in a balloon, opened it up, and left a stent to keep it open, which makes great sense. So a German researcher named Rainer Hambrecht looked at this with about 100 cardiac patients. He got half the group to exercise, and by that I mean 20 minutes a day on an exercise bicycle and then once weekly 60-minute aerobics class. And the other half got the high-tech stent and just their sort of normal activity. And after 1 year, 88% of the exercises were event-free compared to 70% of the people that got a stent. So both worked, but I find it sort of incredible that the low-tech made a bigger difference. And you have to remember that the stent just fixes one part of the heart. The next way to think about it is the reverse. So what I call sitting disease. We know that being sedentary is bad for your health, but a researcher named Leonard Veerman wanted to quantify this, and he did so down in Australia in a big study they did there. They found, compared with persons who watch no TV, those that spend a lifetime average of 6 hours a day watching TV can expect to live about 5 years left. I mean, that's incredible. But then I think, who watches 6 hours a day of TV? And it turns out the average adult in the USA spends about 5 hours a day watching TV or screens. So I find this fascinating that we never think of the TV as something that's bad for our health, but clearly it's as powerful as many other risk factors for chronic disease. So I'm just going to leave you with, I guess, two quotes. So one is Jerry Garcia, the singer who is the lead singer for the Grateful Dead, and he said, somebody has to do something. It's just incredibly pathetic that it has to be us. And I think that's true, that in some ways it has to be us. As Hippocrates said, walking is man's best medicine. And so I'm going to finish by asking you a question. And this may have some personal challenges for you. So, you might be very busy with work or kids or both, and you may be in pain or have other priorities. But my question to you is, can you limit your sitting and sleeping to just 23 and a half hours a day? So something to think about. Thank you very much.
So the recommendations after a diagnosis of cancer and for cancer survivors is aiming for 150 minutes of moderate exercise per week. As you saw in the previous video, you can actually break that into 3 10-minute sessions, but the aim is for that 150 minutes or 75 minutes of intense exercise per week. We also recommend strength training and stretching at least twice per week. Strength training builds muscle mass, and we need that for our bone strength. But additionally, the more muscle mass we have, the more capacity we have to burn calories if we're looking at weight reduction or weight maintenance. So studies have shown that active cancer survivors have a lower risk of recurrence and certainly improved survival from all causes. And exercise has been associated with this decreased risk of breast cancer from anywhere from 24 to 34%. And Interestingly enough, there are a number of trials now that have demonstrated that physical activity is not only safe, but actually decreases the incidence and the severity of lymphedema in women with breast cancer. We've talked about smoking and its influence on some of the side effects of treatment. Additionally, we know that smoking can increase the risk of recurrence, and it is also implicated in some primary cancers such as lung and bladder. We know that smoking cessation, if this is what you're thinking about, is not easy, and there are a number of resources available. At the Cancer Center, there is a smoking cessation coordinator, and the nursing staff or the providers at the Cancer Center can help you connect with her. Additionally, there are programs at the Heart Institute, and the primary care providers have a number of tools available to them if this is something you wish to pursue. Additionally, the website at the bottom of the page has a lot of useful resources, and we would encourage you, if this is something you're thinking about, to have a look there as well. I'd like to take a brief moment to talk about complementary therapies very briefly. Complementary therapies are also used with conventional medical treatments. There are a lot of reasons people use complementary therapies, particularly during survivorship. Sometimes it's to relieve side effects associated with their treatment, taking an active role in preventing recurrence and improving your overall health. And we often use complementary therapies for other medical treatments, such as heart disease and diabetes. We've mentioned many of these today, things like vitamin E, calcium, vitamin D, massage and acupuncture, and yoga, and even exercise and nutrition are complementary therapies. The thing that I think is important is letting your provider know that you're also using complementary therapies. Some therapies will have interactions with your other medications. So things like ginkgo, for example, or garlic increase bleeding times, and if you're on blood thinners, that can be a bad effect. And one of the examples I think of breast cancer was one that I learned more recently. So there was a treatment called Siberian ginseng. And Siberian ginseng has an interaction with the drug tamoxifen, and it binds with it, making it less available to do the job that it's intended to do. The important thing about this is not to take complementary therapies, but if you are doing it, to let your provider know so that they can ensure there's no interaction with your other medications. And if you're going for massage or physiotherapy, letting the person treating you know that you've had cancer and where that is so that they can treat you appropriately and make sure that you're getting all the benefits necessary. So let's recap and review.
So, important symptoms to report. Well, remember we talked about the importance of regular monthly breast reconstruction, and mastectomy site self-examination, and reporting any new lumps, bumps, nodularities, or changes in texture of the skin. Also, spontaneous clear or bloody nipple discharge, meaning when you wake up perhaps and your nightie is wet with either a clear or a bloody discharge. Also remembering as part of the breast self-exam to visually inspect the skin and looking for such things that may include pink flush of skin that arises from the scar area, blistery type effect of the skin dryness in a particular area, and so on. Dry cough, new shortness of breath. Obviously, if it's acute shortness of breath, that's something different. It's cardiovascular in nature, and you should report yourself to emerge if it's sudden onset. New and persistent bone pain, a pain that perhaps may wake you up in the middle of the night or isn't relieved by an analgesic. Some patients report it as being a toothache type of discomfort in the bone. And also vague symptoms such as an increased or unusual fatigue, nausea, abdominal discomfort, unexplained weight loss. We've talked about the importance of maintaining healthy body weight and fueling the body with good nutrition. But if you're losing weight and not intending to, then that's an unexplained weight loss that you should be reported. And also change in balance or visual problems. The 2-week rule is a rule that patients have reported to us as being one of the most important things that they have learned from this education class. And the 2-week rule, what it is, it's a rule that healthcare providers live by. And what it means is if a symptom comes and it persists and doesn't improve after 2 weeks, then that's the indication or the cue to seek attention. However, if the symptom goes away within the 2-week span, then you know that it wasn't to worry about, and that can really give peace of mind. For example, if you were doing your breast self-exam and you felt under the armpit area a spongy area or a nodularity that was concerning, but you're not too sure about, then you put a little X on the calendar, for example. Wait for 2 weeks, and if it's still there, then you would want to report that to your primary care provider. But if it went away within the 2-week period, then you know that it wasn't to worry about, and likely your body was fighting an infection or perhaps a virus, like a cold virus or a flu bug. Be aware of your body. Trust your instincts. Nobody knows your body like you do. Don't wait until the next scheduled appointment if you have a symptom that is persistent. Remember, we talked about the importance of regular interval follow-ups with your primary care provider? If you develop an interval symptom, however, then you don't want to wait till that next scheduled appointment. You want to be proactive, pick up the phone, and notify a healthcare provider. So who is it that you contact? Well, if you've been discharged to your primary care provider, then it would be their office that you would call. And then they would assess you, and if they require any advice or if they want us to schedule an appointment with your oncologist for you to be reassessed, then we would arrange for that. If you've been discharged and are being followed by the Wellness Beyond Cancer Program nurse practitioner, then you would call the Wellness Beyond Cancer Program phone number, and we would notify the nurse practitioner and schedule you an appointment as needed. Other programs and resources around survivorship care that you may wish to consider are listed here on this slide. The MapleSoft Survivorship Center is located on Alta Vista Drive in Ottawa. For further information around their resources and services, you can access their website, which is indicated here on the slide. Also, their phone number is listed should you wish to register for any of their programs. Cancerandwork.ca is a great website that you can access as well if you're thinking about returning to work. It is a site that is not only for patients, but it's for healthcare providers and also employers. Thank you for listening to our Wellness Beyond Cancer Program breast education class. Should you be a patient that's being referred to our program, we look forward to seeing you in the near future.